All right, so we're going to talk about cardiac muscle, some of the unique features of it and how it differs from skeletal muscle. So first of all, if we look at this diagram of cardiac muscle, those muscle cells are branched. They have T-tubules to bring that calcium in, but they have something unique, and that's those intercalated discs. And you looked at that in lab. That's those dark lines. Can't see it very well in this tiny picture here, but those dark lines, there's two things that are present at those dark lines. There's gap junctions, which are special openings in the membrane between each of the muscle cells, and there's desmosomes that tether the cells together. Intercalated disc, yep, intercalated disc. So what that essentially does is that the heart muscle cells are tethered together so that when one cardiac muscle cell contracts, it pulls the other ones alongside it. And they're contracting as well. So they all contract as a unit. And if you look in the notes underneath, that's called a functional syncytium. It's the fancy word for just saying it functions as a unit, one solid structure contracting together. So the intercalated discs make that happen. So we have gap junctions, which means if I have sodium coming into a cell, starting an action potential, that sodium can flow right into the next cell through the gap junctions. So the electrons flow from cell to cell through these doorways that connect them. So each cardiac muscle cell doesn't need a branch of an axon terminal or of a motor neuron, right? Like in skeletal muscle cells, remember the motor unit was a branch of the axon terminal? We don't need that in cardiac muscle cell. We just need some cell or neuron serving the heart to generate an action potential, and that action potential can spread throughout the heart going down the conduction pathway, which we'll talk about a little bit today too. So cardiac muscle cells have intercalated discs, and they're made up of desmosomes and gap junctions, lots of mitochondria. See, if you look inside a cardiac muscle cell, we'll see lots of mitochondria because the heart is constantly functioning to beat and pump blood from the minute it starts in utero to the minute we pass. There's constant activity in those heart muscle cells, so they need a ready supply of oxygen because you know mitochondria, what two processes are occurring in the mitochondria? Right, Krebs cycle, electron transport chain, and those are aerobic processes, right? They need a steady supply of oxygen. Cardiac muscle cells don't like the anaerobic pathway. When they have to rely on the anaerobic pathway, when there's a clot in a coronary artery and there's no oxygen feeding those cells, they switch to the anaerobic pathway, and lactic acid builds up in cardiac muscle cells, and that's what is causing chest pain. When people have chest pain, that's lactic acid fermentation occurring in those heart muscle cells, and it causes pressure, pain, discomfort. And we talked about referred pain when we looked at the nervous system. That can go up the jaw, go down the left arm. They feel numbness and tingling down the left arm, and that's because of lack of oxygen flow to that heart muscle cells, those heart muscle cells. So how do we fix it? We open up the vessels of the heart by giving people nitro to dilate those vessels. We up the oxygen if they're with us in the hospital. We crank up the oxygen, and we call the doctor, right? Hoping to do something more invasive, maybe putting them on a nitro drip going in through their IV so they have constant supply of nitro. Because you can put a nitro in, and then that chest pain can come back. So just depending if they were doing something, exerting themselves when it happens, sometimes resting, taking a nitro, that takes care of it. But if they're just sitting there and it happens, that's when they usually are in the ER and they're admitted, and then they put them on a nitro drip until the pain is gone. So branch cells, lots of mitochondria, one nucleus per cell, and those intercalated discs. So we're going to look at the action potential then of the cardiac muscle cells today. And we know in the skeletal muscle action potential, sodium and potassium are the key players, right? Sodium causes depolarization and potassium causes repolarization, right? Well, in the cardiac muscle action potential, calcium comes into play. And there's two types of action potentials in the heart. There's action potentials of the contracting cells, which are 99% of the heart. They're just contracting cells that are waiting for ions to come either from direct stimulation from a neuron or an AED, right, or a pacemaker, or something from the cardiac conduction pathway. So the SA node, AV node, all that. So those are just waiting for an action potential, the 99% of contractile cells. But the 1% of pacemaker cells that are on the conduction pathway, they can make their own action potential. They have channels that just open automatically at negative potentials, and they just drift open, and they fire off their own action potential. So that means I could take a heart from a person and put it in someone else, and it'll beat on its own. Because of those 1% of pacemaker cells, they generate the action potential. It flows down the conduction pathway, and the whole heart contracts in response to those pacemaker cells. So that 1% of cells, they're really important. So if we look at how fast the different parts of the conduction pathway contract, the SA node can produce an action potential about 70 beats per minute. But actually it's 100. But the parasympathetic neuron serving the SA node slows it down a little bit to about 70 to 75. But if we disconnected it from the nervous system, it would fire at 100 beats per minute. And then the AV node's a little bit slower at 40 to 60 beats per minute. And then if we continue down the conduction pathway to the Purkinje fibers, it's about 30 to 40 action potentials a minute. So if we look here at the action potential of a cardiac contractile cell, so 90% of muscle cells, they start an action potential here at negative 85 from ions flowing maybe through a gap junction, right, from a nearby cell. We have sodium causing depolarization here, number one, just like we saw in skeletal muscle. And then we get to the top, potassium channels open, and we start to see a dip downward, right? As potassium leaves the cell and makes more negativity inside the cell, right? But then at the same time as potassium channels open, calcium channels open at the top. And where is there more calcium? Inside our cells or outside of our cells? If you think about calcium comes in through our diet, it's found more outside of our cells, right? Out in the interstitial fluid. So when calcium enters the cell, that keeps it a little bit more positive. We don't see this dip into the negative values, because remember, when potassium channels open, potassium is leaving, and those are positive ions leaving the cell, making it more negative inside. But potassium entering at the same time flattens it out a little bit. And the benefit of that is that when the cardiac action potential begins and it contracts, it stretches out that activity, and it gives more time for the heart to empty and fill with blood before the next action potential starts. Because if we had too rapid of an action potential, that wouldn't give time for the heart to fill with blood, and we'd be starting the next action potential. So it just stretches that action potential out to give a little bit more time. So that calcium is really important. It creates what we call a plateau. So maybe you should underline that. The calcium at the top causes that flattening out. Right. Exactly. Yep. Yep. So again, calcium channels open, flatten out that plateau, lengthening the absolute refractory period and allowing the heart more time to fill with blood. So if we have a really rapid heart rate, that doesn't give enough time for the heart to fill with blood, and every time the heart beats, there's less blood coming out, less blood going to the brain, and people pass out very quickly at really, really high heart rates. So we need to fix those when they happen. So looking at the conduction system then, we said 99% of cells just respond to an action potential in a nearby cell. But then the 1% of cells are shown in yellow here. So the cells that follow this conduction pathway are that 1%. We call those the pacemaker cells because they can generate their own action potential. And here are those values again. The SA node has the parasympathetic neuron serving it, so it slows it down a little bit to 75. Like I said, if we snipped that parasympathetic neuron that's synapsing on this SA node, we would see it beat at 100. So anyway, so we know that if part of the SA node or the whole SA node shuts down, someone has a heart attack and it damages those cells in the roof of the right atrium, then what takes over? What's the next fastest? If the SA node shuts down because of damage to the heart, then the AV node takes over. And what will their heart rate be?
40 to 60.
Yeah, 40 to 60. And let's say that shuts down. Sometimes that happens. We have what's something called heart block, where the atria and the ventricles are not communicating with one another. How fast will the ventricles beat? 30 to 40. That's a pretty low heart rate, right? So when people have complete heart block, we usually need to intervene in some way to get that heart beating a little faster. And ways that we do that, when there's problems in the conduction pathway, that's when people need pacemakers placed to where there's wires going to the heart muscle, and that's generating the action potential. We're not relying on the conduction system anymore. So the SA node is in the right atrium. When it fires, that action potential goes across and helps the left atrium contract as well. So when the right atrium contracts, the left atrium contracts together with it. And then the pathway goes down the middle of the ventricles, up the Purkinje fibers, and then the ventricles contract together. So the atria contract first, then the ventricles contract. So it's a side-by-side pump contracting together, right? So the left and right side atria contract, left and right side ventricles contract next, and then we have that flow of blood. So if we look at an action potential of the 1% of cells, it looks like this. We have a slow drifting of those cells that when the action potential is done from the previous one, down at -60, that triggers voltage-gated slow sodium channels to open automatically without a stimulus, just, the end of an action potential. They slowly drift open, and then we see a rapid spike where voltage-gated calcium channels come to play again. And that's what causes the rapid spike. And this, again, is only in those cells of the conduction pathway. So we're talking about just the cells that are found in the yellow conduction pathway, this 1%. They have a special graph of their action potential. So this is called a pacemaker potential, this sodium portion where it's drifting upward to threshold, because it happens all on its own. It doesn't need a stimulus. It just drifts. These channels just open automatically. And then once it reaches threshold, again, calcium causes the upward spike. And then potassium takes over and causes repolarization again. So key concept, I'm not going to expect you to know the details of the cardiac action potentials because that's more of an advanced A&P concept, but this is just a little introduction to it. So I'm going to ask you to know that calcium is another player in the cardiac action potential. That's what I want you to know at the general A&P level, that not only is sodium responsible for the depolarization, but calcium also helps with depolarization, maintaining that depolarization before repolarization is through potassium, right? And not all the cells of the heart are the same, right? Contractile cells don't need an action potential. They don't need to generate their own action potential. They rely on the conduction pathway. Or they have a neuron that stimulates them. The sympathetic neuron can stimulate them and send an action potential to those cells. So the refractory period is longer in a cardiac muscle cell. Would you agree with that? Which means when we're in an action potential, if you look at the time of that action potential, it's longer. So it's 200 milliseconds longer than a typical skeletal muscle cell. So we can't stimulate that heart muscle to contract again until that action potential is over. And that, again, gives the heart time to fill with blood and prevent, too fast of contractions so the blood flow isn't sufficient. So if we look at an EKG, this tells us what's going on in the heart. If I look at this EKG, the different parts of it, we have the P wave, which tells us that the atria are depolarizing. Then they are repolarizing at the same time that we see the sharp QRS complex. This is when the ventricles are depolarizing, getting ready to contract. So these are electrical activities. It's not showing contraction, but we can assume contraction is going to happen if we see depolarization occurring in these chambers, right? So we can see that the atria depolarize first because time is what goes along the bottom of this graph. So the atria depolarize and the ventricles depolarize, and in the middle of this graph, this portion, the QRS, is when the atria would be repolarizing, but we don't see it because it's buried in the QRS. And then we see the ventricles are repolarizing with the T wave. So be able to just know what's going on this EKG. We've got the P wave, the atria depolarizing, the the QRS, the ventricles, and the T wave is the ventricles repolarizing. So QRS, the ventricles are depolarizing, getting ready to contract. And the ventricles are pretty large number of cells, right? So you see a pretty rapid spike there. Where the atria, pretty tiny, so we don't see a big deflection off of the horizontal line for the P wave, right? So we see that big deflection there. So if I see a QRS that's really wide, that's a sign of a bad ventricular rhythm occurring, and we need to look at that and figure out why that is occurring. Because if the atria are stimulating the ventricles through the conduction pathway, we should see a rapid, narrow, tall spike for the QRS. And that represents a heartbeat. When the ventricles contract, right, that's a heartbeat. So when we look at an EKG over time, we look at those Rs, that tallest peak there is the R. We just look at the pacing of that R, and that tells us what the heart rate is. We can count the number of Rs over a period of time on that rhythm strip, and we can figure out heart rate that way. So there's a nice little animation you can watch here showing the EKG, which is a good thing to review, so be sure you look at that. You can type that in. So another concept related to EKGs is just looking at the cardiac cycle, and the EKG matches the cardiac cycle. So if we look at how the heart works, like I said, it's a pump side by side with contraction of the heart, which we call systole. So when we talk about contraction in the heart, the term for that is systole. And the relaxation of the heart, of the ventricles and atria, is called diastole. It looks like systole and diastole, but it's actually systole and diastole. And if you've ever watched Grey's Anatomy, maybe you've heard, you know, he's asystole, right? A means not, systole, contracting, heart stopped. All right, so you have a really nice diagram in your textbook of the cardiac cycle as well. And this is on page 686 of your textbook. So the first part of it begins with filling of blood. So what happens is you have the two atria at the top of the heart are receiving blood from the veins. What are the veins serving the atria? The superior and inferior vena cava lead to which atrium? The right atrium. And then the left atrium, what are the veins leading to that? Yeah, the pulmonary veins bringing fresh blood from the lungs, right? So we have this flow into the atria. It's called venous return. We have these veins bringing blood back to the heart. Well, the atria are open, and the AV valves going to the ventricles are also open during this time. So blood is just filling those ventricles passively. 80% of the ventricles fill through open AV valves, just bringing that blood in. So it's passive. There's no contracting going on yet. Well, the SA node fires, then the atria contract, and whatever blood is in there at that time fills the rest of the ventricles. So only 20% of the ventricles are actually filled by the atria contracting. And this makes a lot of sense because can someone with atrial fibrillation, where their atria just kind of quiver and they don't really fully contract okay, can they be okay and survive with that? Yeah, because the ventricles are 80% full just by the veins bringing blood and just kind of like filling a swimming pool. There's just the veins pouring blood into those ventricles through the open AV valves. So phase one, is just passive filling. 80% is passive. Then the atria contract when the SA node fires, and that fills the other 20%. Then that action potential is traveling down the pathway, down the bundle of His to the bundle branches, up the Purkinje fibers, then the ventricles contract. And there's a brief period of time when the ventricles contract where pressure is rising in the ventricle, and that slams those AV valves shut. And that's when you hear the lub of the heartbeat, the lubbed up, right? So the valves close at the lub sound, and that's when the ventricles are just starting to contract. So we call that short period of time when the semilunar valves have not opened yet at the base of the aortic, at the base of the aorta, the pulmonary artery, And the AV valves are also closed. So the heart, the chambers are a closed unit here at the bottom of the heart, the ventricles, and that's the period of isovolumic contraction. So that's the first heart sound at the end of that period. Then pressure is high enough to force those valves open at the base of the aorta and the pulmonary artery, and that's called the ejection phase. So blood is actively leaving the heart. Then the heart relaxes, and this is during that plateau phase, right, and repolarization just after that. The heart relaxes, and again, the blood flows back toward the heart, but as it flows back in the aorta and the pulmonary artery toward the heart, it shuts those valves. That's the second heart sound. That's the DUP. So the AV valves have those strings attached. They're much larger, more structurally sound valves, so when they shut, we hear the lub. Isn't that like a longer sound when you say lub versus DUP, right? So the valves at the base of the aorta and the pulmonary artery are smaller, and they shut and make a more distinct sound. It's the DUP sound. Now, what would happen if I had some sneaking of blood through, if I had an incompetent valve, which means it didn't shut completely, and I had blood backflowing? We have heart murmurs, and that's a special sound that you'll hear. You might hear like a whoop, dup, whoop, dup. That's what I hear when I hear a pretty significant murmur, and that's where you're not hearing that lub, dup, lub, dup. It's like a whoop, dup, whoop, dup. That's a murmur. So if you ever have a chance to listen to that, be prepared for that. And a mechanical valve, an artificial valve, also gives that sound. It just is not a clean sound as our natural valves make. Correct. And the semilunar valves at the base of the aorta and the pulmonary artery are the DUP. So we had that brief period where everything is closed again and the heart is relaxed. So it's called isovolumic because there's no blood entering or leaving the ventricles during that time. And then the process starts again. We have passive ventricular filling, active ventricular filling when the atria contract, and then it starts all over again. So when we look at a person's heart function, we look at cardiac output. So when the heart is contracting, how much is leaving that heart per minute? And it should be about 5.25 liters in a healthy adult male in his 20s. And stroke volume is a term that we use to describe how much is leaving the ventricle per beat. So we have something called end diastolic volume and end systolic volume. End diastolic volume is how much is in that heart when it's relaxed at the end of filling. Okay, so when it's all relaxed, before it contracts, how much is in there? And it's about 120 mils. Then when it contracts, that's called stroke volume, right? The amount leaving the ventricle when it contracts. So after one stroke volume leaves, how much is in there at the end of contraction? We don't pump out all the blood from one contraction. We pump out most of it, but about 50 mils remains in the heart at the end of contraction. That's called end systolic volume. So the difference between that is how much left, right? If I fill up your cup, that's end systolic, right? So if I fill up your cup with 120 mils, right? And then you drink some of it, and you set it down, and there's only 50 mils in there. That's the end systolic volume. There's 50 mils left. How much did you drink? 70. And that's what stroke volume is. Stroke volume is we should be pumping out 70 mils of blood with every beat from each ventricle. What happens, do you think, if you have heart failure because of long-term high blood pressure and your heart is just weak and it can't squeeze that 70 mils out? Which value is going to be higher? Yeah, the end systolic volume is going to be higher. And then that causes a backing up of blood because you still have the veins bringing blood in, right? Now you've got a heart that's stretched out and getting weaker and weaker and weaker, and that's why heart failure is one of the #1 reasons, you know, we have cardiovascular disease as a #1, you know, killer in the United States, and heart failure is a huge population of cardiovascular patients that are hospitalized over and over and over again. And what should they not be doing if you have heart failure? Should you be eating salty foods to draw fluid into your blood vessels? No, now your weak heart has got more blood to try to move. Should you be drinking normal amounts of liquid? Should you be drinking lots of fluids? Because I had a relative tell a family member who was hospitalized for repeat fluid overload from heart failure saying, well, make sure you're drinking lots of water. No! Those people actually are on fluid restrictions where they're walking around thirsty most of the time because the more water they drink, the more that goes into their bloodstream, and if their kidneys aren't peeing it out like they should, it stays in the blood and their heart is already weak and it's working that much harder. So we limit fluids and we limit salt in people that have heart failure. So the heart pumps about 60% of its volume per beat. We call that the ejection fraction, and that's a number that we look at in people that have heart problems. We look at, what is their ejection fraction? Anything below 55% is considered heart failure. So how do we keep our heart healthy? The heart has the ability to kind of monitor things that are happening throughout the body. So if pressures are getting too high, we have pressure receptors in our carotid arteries and in the aorta that will kick in. If pressure is too low, the SA node will fire more rapidly and we're going to increase the heart rate, right? If pressure is high, that will decrease. That'll inhibit that sympathetic response. If we have low pH, high carbon dioxide, low oxygen, we have chemoreceptors that will monitor that. And a lot of this monitoring happens through the medulla. The medulla oblongata is the major controller of the heart. And when we have a fever, what happens to heart rate with a fever, do you think? It increases, yeah, because the body's working harder. And that heat production causes a higher demand for oxygen, so we see a higher heart rate. How about dehydration? Increased heart rate, yeah, because we're dehydration, less blood volume, lower pressure as a result of that, so the body's trying to make up for it with a higher heart rate. So we call these extrinsic controls because they're controls that are happening outside of the heart itself. So here's just some of those examples. We have the medulla that has neurons that go to the carotid artery. So when there's a change in pressure, that stimulates that sensory receptor in the carotid arteries, giving information to the medulla, and the medulla will stimulate the heart through the SA node via parasympathetic or sympathetic nerve fibers to speed that up. And we also have nerve fibers that go to the adrenal medulla to secrete epinephrine, which is the stress hormone, which will also act on the heart and speed things up. So depending on what the needs of the body are. So when we get old, what do we get to look forward to on the heart? Well, we see maximum heart rate decreases. So as we age, our heart rate goes down. The left ventricle gets larger. And why would that happen? Why would the left ventricle get larger? Okay, weaker. Because where does the left ventricle pump to? Yeah, the systemic circulation, right, through the aorta. And if you have narrowed vessels because of cardiovascular, disease, hardening of the arteries, high blood pressure, that's going to cause blood to back up eventually. And we know that it gets thicker. We know that the left outer wall of the left ventricle is thicker because it has to work harder than the right side. So the left side of the heart is a higher pressure side, correct? Everybody agrees with that? And then the right side is lower pressure. But are the volumes any different? No. It's still, stroke volume is 70 mils per beat, whether it's left ventricle or right ventricle. But now if one side is failing, obviously you're going to see a difference in stroke volume. But in a normal, healthy heart, we should see equal volumes of blood leaving the heart. So increased tendency for the valves to function abnormally, that definitely happens because those valves are working hard over a lifetime. A lot of people in their 80s, even healthy people, need to get a valve replaced because it's just not functioning like it should. So we use pig valves in some people, or we use artificial valves, mechanical valves. Arrhythmias, the most common arrhythmia is atrial fibrillation, and that's where the atria start to quiver and have weak little contractions. So what would you expect to see on the EKG if they have atrial fibrillation? What? Yeah, instead of one solid little P wave, we see little tiny abnormal P waves that are not really even distinguishable from one another. Oops, I forgot the T wave. So we see a T wave, but then we see these little wiggles of the P wave. Instead of one nice solid P wave, we see little scribbles of a P wave, then the QRS, and then the T. So they can function okay on that, but some people do feel a little shortness of breath. Something doesn't quite feel right when they're in atrial fib, so they go to the doctor, they get that diagnosed. And sometimes they'll just put them on a medicine to slow the heart rate down, because sometimes atrial fibrillation can cause higher heart rates, depending. But the biggest concern is when the atria aren't contracting, the blood isn't flowing as efficiently as it should. Remember that 20%? When the SA node fires, empties those atria into the ventricles. But if they're quivering and not really fully contracting, blood pools. And when blood stops flowing, what does it tend to do? Do you know? Clot, coagulate, yeah. So if we have blood that's not moving, it tends to clot. And if we get a clot in an artery going to the brain, that's stroke. A clot going to the lung, an artery over the lung, that's pulmonary embolism. And then a clot getting stuck in the coronary arteries is heart attack, right? So people that have atrial fibrillation that don't get it diagnosed and get on a blood thinning medicine like Coumadin or warfarin, or there's new ones now like Eliquis that's out there, if they're not on a blood thinner, they're at risk for all those complications. And I know people that have said, oh yeah, I have atrial fib, they told me that, I'm not going on medicine. And within months, they passed away from blood clot, from stroke. So it's really, really important that people take their blood thinners if they have atrial fibrillation, and take that seriously, because you can live a long time with atrial fibrillation as long as people are taking their blood thinners. And sometimes they can even kick people out of atrial fibrillation by doing a cardioversion, where they sync an electrical zap to the heart with the natural heartbeat, and they can kind of shock that cardiac conduction system back into rhythm again. So I've seen that in younger patients, that they can correct it actually, or they convert sometimes all on their own. Some people flip into AFib and they flip out of AFib all on their own. And we'll watch it on the monitor. There'll be a couple of nurses standing around and say, oh, he just converted. And we call that normal sinus rhythm, when they convert back to the normal P wave, QRS, T, P wave, QRS, T.